next talk by Professor Friedrich. It's from McGill University in Montreal, in a very different area of research. And he will talk to us about combined brain-heart OS-MRI in psychiatry. We're eager to listen to your lecture, Professor. Thank you for being with us. It's very early over there, right?
No, I am actually not far away. I'm in Italy, so don't worry. I'm just 1 hour behind. Yeah, so okay. Thank you very much for the introduction, and also special thanks to Sophie and the organizing team. It's a pleasure for me to participate. Although my task is not very easy, I'm talking about something where virtually no data exists, and so I can only report on the concept, the need, and some very preliminary results. Before I start, I want to point out that I'm involved also in software development, the software that is needed sometimes to get all the information out of the images. So what I will be talking about is oxygenation sensitive CMR. And the basic principle is the following. So MRI is inherently a molecular imaging technique because the signal we're getting comes from protons, and the protons are not giving a signal due to the resonant behavior, which I'm not going to go too deep into the physics, but they give this signal based on their molecular environment. So wherever the proton is, the molecular environment counts and will predict the behavior of this proton in a magnetic field, especially when used in an MRI experiment. And one of the key molecules there, or atoms, there is iron. And iron is part of hemoglobin. And that's why hemoglobin has certain magnetic properties that makes it different from lots of other molecules. And it was already close to 100 years ago when Linus Pauling identified that deoxygenated hemoglobin acts differently in a magnetic field when compared to oxygenated hemoglobin. So if they behave different in a magnetic field, that makes them behave differently also in MRI images, which in other words means it will matter for the signal intensity in an MR image that is sensitive to this type of relaxation speed, which is called T2 star. It's similar to T2, but it's the T2 that is affected by inhomogeneities of the field. So T2 star is a little bit shorter even than typically than T2. And T2 star is affected by the presence or absence of deoxygenated hemoglobin. Or yet in other words, deoxygenated hemoglobin acts in these images like a black contrast agent. So the signal intensity drops. So this is important to keep in mind. This is the basic approach we're using. So this goes, the reason for that is visualized here. So the T2, the observed T2 depends on the Y, which is the term for oxygenation here in this figure. So oxygenation will, and I apologize for the typo, this should be Jang without the D at the beginning. So the signal intensity in T2 star-weighted images will highly depend on oxygenation, but also to some extent on hematocrit. So that's a confounder. It's not huge, but it's a confounder. So this is the background, and this was first shown in the brain actually 25 years ago in this paper by Ogawa and co-workers, and they could show that in the brain this is exactly happening. So the oxygenation correlates with the signal intensity and can be used to track oxygenation in the brain. This this paved the way for what we now know as functional MR of the brain. In the following 10 years, it was mainly the work of Wolfgang Bauer from Mannheim and then Würzburg in Germany, who then provided all the theoretical framework how this could happen in the heart. So he could show that indeed in the heart, it's the same thing. Oxygenation is reflecting the signal intensity. However, we have to keep in mind there are other confounders, other factors that lead to an inhomogeneous field may also have that effect, which is turbulent blood flow then susceptibility artifacts. So the border between lungs and myocardium, for example, or pericardium. So this is typically a spot where there's some inhomogeneity because there are some very different tissues around that. But if you focus on the myocardium, you can actually use this. And we have performed a long time ago on the first clinical trial in patients with ischemic heart disease, comparing with nuclear medicine, and we could show that the basic principle worked. But the image quality at that time was not sufficient to apply it clinically. Fast forward, in Calgary, with the help of Rohan Dharmakumar, we worked on a sequence that has since then been used, steady-state free precession technique that is also used for regular cine images. And they actually look like cine images, and as shown here by work from Germany, from a working group in Ulm, it actually, using this technique, if you give adenosine, there's a signal intensity increase, and this is blunted in patients with a reduced FFR with a coronary artery stenosis. So if you give adenosine, which is a vasodilator, you provide a lot of oxygenated blood. So the deoxygenated blood drops because you don't use more oxygenated oxygenation. So there's a signal intensity increase, which is not present if the vessel cannot dilate. So this is done with adenosine. Now, we have, even at that time, already worked on something which we have now more refined, and that is using a phenomenon that is very interesting. Carbon dioxide in our blood acts as a vasodilator in the heart and the brain. And this has been shown, again, this is almost 60 years ago. If you increase your carbon dioxide, your blood flow in the coronary arteries will increase. And if you decrease the carbon dioxide, it will decrease. Which means if you simply perform hyperventilation, you breathe out more carbon dioxide than you produce, unless you run during that time. So if you breathe a lot of the carbon dioxide out, your coronary blood flow will actually be reduced by about 25%. And then if you then hold your breath, even for just 30 seconds, your coronary blood flow will actually double. Because during the breath hold, carbon dioxide is produced, it's not exhaled, so there is a vasodilatory effect in the heart and the brain that affects oxygenation. So you have more oxygenation, less deoxygenated blood, the signal intensity will be higher. Because we're using a cine sequence with our tests, we could actually look at what happens with the oxygenation across the cardiac cycle. And this is what we've done. This is a paper that is now currently in revision. We have seen that patients with proven endothelial dysfunction with injection of acetylcholine have a reduced response or a different response to the hyperventilation, but also to the breath hold, and especially to the breath hold. So using that, we have an accuracy of a very high accuracy of close to 90% to identify endothelial dysfunction, just with this simple breathing maneuver. You hyperventilate, and then you hold your breath, and you watch what happens with the signal intensity across the cardiac cycle. And this has also been published, or not yet, it's in press, a paper. With this one, we could also show that actually this is not correct, it was below 0.05, that in patients with COVID-19, you have a decreased response. And we have even gone one step further with a cardiac application, that in these images that look like cine images, we also extract information on strain, which is fairly easy because of the deformation. But we can also look at tissue characteristics using artificial intelligence. And this is a paper which is now in revision, that we could identify scars and reconstruct LGE images from these very same images, non-ischemic scars. So we could show that again with a very high diagnostic accuracy. So again, an area under the curve of more than 0.9 to identify and quantify scars. So this is where I think this is a very interesting avenue for cardiac MR. You have one scan where the data acquisition only takes 40 seconds for 2 slices. And then you have all this information on tissue characteristics, on function, and on vascular function. Now, this is also known in the brain, and now I'm coming to the brain. So when you hyperventilate, your carbon dioxide drops, and with that drops the signal intensity in oxygenation-sensitive images. So it is a very similar response, although it's not the same. And then when you hold your breath, that has also been shown in the brain, the response is a kind of a re-establishment of the oxygenation during a breath hold, and even an overshoot. So this is the protocol that we are currently using. It's a 10-second short breath hold as a baseline, which means there's a normal vascular tone. And then there's hyperventilation. So we ask patients to just breathe deeply 30 times, 1 second in, 1 second out, which gets their system into vasoconstriction in the heart and the brain. And then we ask them to breathe out, which is very important, not during inhalation, but we breathe out, and then ask them to hold their breath. And during that time, we acquire data for 30, 40, ideally for a minute, which is not too difficult after hyperventilation, but 30 seconds is what by far most of the patients do, actually more than 90%. In several centers, more than 95% of patients can do that easily. And I know that Athens has already done quite a lot of this work in the heart. So this is the protocol we're using. So the data acquisition is just this and this. So this could be an ultra short, ultra efficient protocol. Now going back to the brain. So let's keep in mind that the human brain needs a lot of oxygen. In fact, it has just 2% of the total body mass, but uses 20% of the oxygen. Only the heart and the kidney even comes close to that. The brain cannot store oxygen, so it has to extract it in real time. So it's very important that the brain has a continuous, predictable, and sufficient amount of oxygen. And in fact, you need that even to think. So we know that a tightly controlled regulation of regional blood flow is critical for cognitive function. If you impair your ability to regulate blood flow in the brain, just within a few percent differences, you cannot do that. You cannot really think. And cognitive function is closely related to that ability. Now, disturbances of blood flow delivery or the blood-brain barrier permeability, they can occur or typically occur before people have symptoms, before there's evidence of neurodegeneration or dementia. So that's why assessing the vascular function in the brain is in these days very important, where we know that most of our reduced quality of life in our societies go to cardiovascular disease, especially atherosclerosis and dementia. And atherosclerosis is also accompanied by heart failure. So those are the big topics in our medicine. And therefore, it's so important to understand very well what happens in the brain. Now, recently, there have been attempts, and there was even a statement of the American Heart Association, who and they coined the term neurovasculome. So, which means the vascular system in the brain is extremely important and is vulnerable to risk factors, to atherosclerosis caused by the primary risk, essentially our lifestyle, which leads to diabetes, high blood pressure, hyperlipidemia, lack of physical activity, and stress, just to name the most important. And we have several stages of the vasculature, starting with the arterioles and then going through the capillaries and eventually ending up in the vein. And the venous and the difference between the oxygenation in the arteries and the veins, that is caused by how much oxygen has been extracted. And that's the cerebral oxygenation extraction fraction. So how much oxygen is extracted. And this is very important. We know that a high oxygen extraction is a good thing in healthy people. But if you're not healthy, if you have if you are at risk, if you already have subclinical atherosclerosis, then it's not this kind of athletic, let me call it like that. In a healthy person, they are able to extract a lot of oxygen, basically think a lot and hard at the same time. Whereas in patients with risk factors, so obese people, atherosclerotic people, smokers, people with diabetes, they are already on a kind of an impaired level, so they will also have a high oxygen extraction, but it's more on the low side. So this is why it's important to measure oxygen extraction fraction. And the way how this is done with oxygenation sensitive MR, it's just simply comparing the venous oxygen saturation in the brain with and measure that with oxygenation sensitive MR with the arterial oxygenation, simply done at a finger, or you could do it anywhere where you have access to the arteries. And here, and this is the simple formula. So this is the difference between the oxygen saturation in the arteries and the veins divided by the arteria. So this is just the fraction, how much in percent, how much it is reduced. And you can perform this calculation for each pixel and then get to maps like this one. So this is an anatomical MRI. This is a blood volume MRI, and here you see the oxygen extraction fraction. So you can see that in certain areas here, there is a bit more oxygen extraction than in others. And then depending on the clinical context, this may mean a lot. And here are some examples from this review, which I can recommend in magnetic resonance in medicine. So healthy people, they have a high extraction fraction. And however, people with dementia, if they don't have a low vascular risk, and these people exist, although vascular insufficiency is the strongest risk factor for dementia, so they have a lower extraction fraction. So they cannot, their dementia does not come along with a lot of cognitive activity, so there is not a lot of extraction. Now, again, in people with low vascular risk, the cognitive score is correlated with the oxygen extraction fraction. So the better they score, the more they extract, which also makes a lot of sense. Yeah. And then if we go to here, people who are cognitively impaired, with the more risk they have, the more the oxygenation extraction increases, simply because they don't get that much oxygen in the first place, and they have to pull out in order to get the oxygenation in the brain or in the veins will squeeze out as much as possible, but there is not a lot to start with because the turnover is already too low, for example, in heart failure. And then you have a higher extraction fraction. So this is just an example of where this is going, and the techniques for that have been improved quite a bit. And this is one of the very good advances in MR imaging of the brain. Now, we have also applied that, and this was published 2 years ago. We had patients with heart failure, and they underwent an MRI protocol, as I showed it before, hyperventilation and then breath hold. And we did that in the heart and the brain in the same people, and had a control group and patients with heart failure. So what we found was quite interesting. People with heart failure, and the strongest predictor for that was actually not ejection fraction, but cardiac output. So with low cardiac output in patients with heart failure, what we saw is that the response to a breathing maneuver, where you usually see an increase, was blunted in both the heart and the brain. And then what was interesting is in the brain, the dysfunction of the vascular system was correlated with cognitive impairment. So we can draw a line here between heart failure, reduced cardiac output, a lack of proper vascular function in the heart and in the brain, and in the brain association with cognitive function. So bottom line here is vascular function is important. Vascular function, which can be assessed with a simple breathing maneuver, where the heart and the brain respond to a hyperventilation with vasoconstriction and to a breath hold with vasodilation. The response then can tell us there is a vascular function, good or bad vascular function, and this correlates with cardiac function, but also with brain function. So the heart-brain axis here has a lot of similarities. But let me go one step further. So this is atherosclerosis, but what about mental health? What about psychological health? And there has also been a strong increase, and a very recent scientific statement by Levine and others clearly says that psychological health, well-being is important for the mind-heart-body connection, and is what we all know is associated with cardiovascular disease. In fact, we know that people with mental disorders that are associated with stress have a much worse cardiovascular outcome. The reason for that is not yet fully elucidated, but I think it is related to a stress response of our body. Stress is a non-specific response of our body to anything, inflammation, allergy, but also stress and expressed as catecholamine overflow. We know this in stress-induced cardiomyopathy, but this is just one end of the spectrum. I think much smaller amounts of stress, if it's chronic and often expressed as sleep disturbances, they have an impact on vascular function. And breathing, actually, which is interesting, is associated with that. So people who are anxious, they breathe more. By breathing more than they need to, they have, unless they do sports while doing that, they tend to be in vasoconstriction. And I think this is one of the reasons why people with panic disorders and anxiety have a higher cardiovascular risk. But I'll come back to that with some of our data. Now, although this connection is known, there are not a lot of data out there. So in this review here, oxygenation-sensitive studies in the brain, they are looking at a lot of things, cerebral vascular disease, of course, and tumors, hemoglobinopathies, but there is not a lot of mental disorder or stress. There are some data from earlier, like here in schizophrenia, where they just looked at the pattern of activity in the brain, and they saw some differences, but they were not necessarily always that reproducible. So we performed a study that is now submitted, and what we did is use the same protocol, free breathing followed by hyperventilation and then a breath hold. And then we measured the response in the heart and the brain, and did that in these people using a cine sequence, and tracked what happens over time. And the first thing that we observed was the response is slightly different, which was not well known. In the brain, so hyperventilation initially leads to a kind of an increase, like an attempt to compensate for that. But then if you continue to hyperventilate, the perfusion drops, whereas in the heart, it drops right away. And then when you go into breath hold, the brain actually takes a long time and even continues after 30 seconds to increase and increase. So this is a fairly slow recovery, if you want. Whereas in the heart, it's relatively fast. After typically about 30 seconds, in the heart, we reach already a very high oxygenation. And even though blood flow may be increased further, it does not lead to a higher increase of the oxygenation, simply because the oxygenation extraction in the heart is already at 70–80%. So that's one thing. And then even if you put in so much oxygen, at some point the oxygenation is saturated, and then the heart also gets freshly saturated blood. So there are explanations for that, but this was the first observation that there's a mild difference. Then when we analyze the signal with custom designed tools to extract the information oxygenation, and then overlay it with the anatomical map, etc. So what we found is that this is a pretty consistent curve characteristic that we can identify, and which we do not address in this paper, even across the cardiac cycle, which is very interesting. So we call this the oxycardiogram or the oxyencephalogram, like ECG, but just with oxygen, how oxygen changes across the cardiac cycles. Also, there will be a lot to learn, like we learned initially about the ECG. Now, then we had a pilot group in pilot study in patients with anxiety, and we found something that we were already hypothesizing. Patients with anxiety have a blunted response, so they respond not that strongly to the breathing maneuver when compared to healthy people. And then this was the case in the heart and the brain, so in both, in parallel. And it was correlated to the severity of anxieties, which means the more anxiety people had, as quantified by a standardized questionnaire, the less their response was. And then even more interestingly, when they were successfully treated with cognitive behavioral therapy and their anxiety normalized, or they did not have that anxiety anymore, they improved. So their function came back to normal, and in fact was not different anymore from healthy controls. So these are just very, very preliminary data, but I'm 100% sure that patients with mental disorders that come with increased stress, and most of them do come with increased stress, be it attention deficit disorders, being schizophrenia, anxiety, with the more severe forms of panic disorders. And because we know that patients with anxiety and panic disorders, they have a higher mean respiratory rate, so they are in constant hyperventilation, I'm pretty sure that this permanent state of slight vasoconstriction alters the vascular system over time. And that's the reason why these people have a 5 to 6-fold higher increase for cardiovascular diseases, especially atherosclerosis. And that's why stress, which comes with hyperventilation, that may be one of the reasons why stress is so detrimental for the body. Now, this also indicates why it is good to have a lot of physical activity, because if you hyperventilate while you're physically active, there is no hypocapnia, there is no loss of carbon dioxide, because you produce a lot of carbon dioxide. It's just when you're stressed because you're looking at your screen with your social media and you're not moving and you are stressed, then you will hyperventilate because your body expects something to happen, but nothing happens with your body, so there's no additional production of carbon dioxide. So you go into vasoconstriction, and I think this is a very important factor to keep in mind. That's why I also think that exercises like yoga, meditation, mindfulness, the key factor of all of them is slow, controlled breathing. And I think this is beneficial because it forces us to get out of that hyperventilation, vasoconstriction, into more vasodilation and more steady pattern. And I think the most important, or the best, is to alternate between the two. That's why I think breathing maneuvers where you do both, hyperventilate and then hold your breath, are the best. And that's why I also think this diagnostic approach using a hyperventilation breath hold maneuver is probably one of the very few diagnostic tests that is also therapeutic. So let me summarize. Both sensitive or oxygenation sensitive CMR is suitable for the non-invasive assessment of vascular function in the brain and the heart. The methods for measuring oxygen extraction fraction are improving, and which is important and will teach us a lot about vascular function in healthy and diseased. And then last but not least, early results indicate a strong association of cerebrovascular function with generalized anxiety disorder. And hopefully soon we will get also more on other mental disease that may reflect the role of breathing patterns for the increased cardiovascular risk in anxiety and other disorders. And that's one of the reasons why I'm here in Italy, because I will spend the next 3 months in Rome at the Sapienza University to help establish a program looking at using this approach in various mental disorders. And with that, I want to thank you very much.
Thank you very much, Professor Friedrich. It was an excellent presentation, very intriguing results, I would say promising results, innovative areas. And thank you for expanding your conclusions to areas of psychology and lifestyle, proper and healthy lifestyle. Is this a method for oxygenation-sensitive MRI a method of testing endothelial dysfunction or something beyond that?
That's a very good question. So there are some very interesting experiments that in healthy people, the response to the breathing maneuver is almost exclusively going through the endothelial function pipeline. So in relatively healthy people, this is a very good test for endothelial, specifically endothelial dysfunction. In people with risk factors where the endothelial function is already impaired, more and more of what we're seeing is they're not endothelial function, but it's more function of the smooth muscle cells themselves. So the atherosclerosis of the wall. So it is the only test aside from acetylcholine that we know that specifically allows to assess endothelial dysfunction. Adenosine, for example, doesn't do that. It goes around the endothelial function. It goes directly to the smooth muscle cells. And other tests that have been used, they're not for endothelial dysfunction. And that's why it's so important or interesting that in younger people who are not, quote unquote, not yet in an atherosclerosis risk mode, this could be a fantastic test to identify those at risk at an early age, 30, 35, and then help them manage their lifestyle. But primarily, so to answer your question, primarily it's endothelial dysfunction, but with advanced stages of atherosclerosis, it also then more and more is dependent on the smooth muscle cells themselves and not the endothelium that then acts as the initiator.
Thank you very much. Before giving the microphone to Dr. Mavrogeni, what do you see looking ahead, clinical implications of this test?
Yeah, that's also a great question. I think because this test is ultra fast, comes with lots of other information, is safe. We don't use any radiation. We don't need a contrast agent. It's very fast. I think this would be a test that should be considered a test for early I don't like the term screening, but to have a tool in patients or in people who are interested in managing their cardiovascular health as a test they could repeat and then see, okay, how fit am I really? How fit is my system? Even though I have no coronary artery stenosis, I don't have plaques, I don't have coronary calcium. This is not what we're talking about. We're talking about something that happens earlier. That's why I think as a tool for tracking cardiovascular health in earlier, at younger ages, I think this is a very good application. We will have to find out, because we also see certain patterns in coronary artery disease where in the coronary territory, it's again another the curves look again different. We will have to find out how much we can do there. But I also think, and there are some studies from Switzerland showing that you can identify the coronary artery territories that are exposed to really severe stenosis. So this could also be used for that. And then where I also see clinical application is in societies that are not the kind of the super rich ones like the United States or Europe, but we have exported that to Nigeria, for example, and they use this in their MRI centers for looking at cardiovascular disease, because they don't need a contrast agent, they don't need adenosine, which is very, very expensive for them. So kind of opening up new possibilities for geographical regions that are challenged by financial settings.
To this end, can I ask you, is there any association with perfusion, for example, with other modalities of MRI? Have you checked that, either with CFR or qualitative perfusion?
Yeah, so there are some very interesting studies from Oxford a few years ago, and they have shown that in several diseases, and Theodoros Karamitsos, who is now in Greece, has done some of that work. Their work could show that perfusion and oxygenation are not the same. And so you can have very good perfusion, but your oxygenation is not good, and vice versa. You can have very bad perfusion and the oxygenation is still good. And the reason is that the perfusion only gives a surrogate marker for the supply, but the demand is different. So for a partially infarcted myocardium, we don't need as much oxygen as for a fully functional myocardium. Hypertrophied myocardium needs way more than, so you have fantastic coronary arteries, but if you have hypertrophic cardiomyopathy, you have oxygenation problem, you have scars and you have risk, etc. So this is not the same. That's why I think quantitative perfusion and CT and this test for endothelial dysfunction, they cover 3 different areas, and they all should be seen as complementary and not in competition. If I have chest pain, I'm not interested in my coronary calcium. That's the least thing I want to know. I want to know, is there an oxygenation problem? Yes or no? And if there's an oxygenation problem, then I want to know, okay, where is it? And is there something I can do something about it? So things like doing a CT for ruling out coronary artery diseases, that's nice for an emergency room, but it's nothing for kind of prevention. And we have lots of people who have a normal calcium score. They have no plaques, but they have chest pain. We have the ANOCA, and we have even published papers on a reduced endothelial function in patients with ANOCA, where it's inhomogeneous. So this is where perfusion doesn't help and coronary imaging doesn't help, but this is where we need a test that is good at testing the function of the vessel. So that's why I think they go hand in hand, but not against each other.
So Matthias, thank you for the excellent talk. You gave an impression of all cardiovascular system, because usually as cardiologists we deal with the heart, but in practice it is cardiovascular. And the best place to examine vessels is the brain. We did also combined studies, combining brain and heart in autoimmune diseases. And we found that indeed the degree of inflammation influences both brain and heart. And we know from previous studies that they have they die earlier, and of course they have smaller brains and more involved by arterial disease in these patients. So in our cases, we found that the myocardial T2 mapping has excellent correlation with hyperenhancement in FLAIR images of the brain. So which means that there is a direct correlation between brain and the heart. My question is, I love this sophisticated approach with breathing maneuvers. However, there are patients, like patients with COPD or patients with lung diseases, which cannot obey these instructions. Can AI help us to make the final conclusion without breathing maneuvers?
Yeah. So as I mentioned before, if people really perform the hyperventilation properly and still cannot do it, one way to address that would be just to let them hyperventilate for not 1 minute, but 1.5 minutes, for example. And it's amazing what people can do. We had people, a lady I remember, 94 years old, heart failure, New York Heart Association class 3. So she could barely walk from bed and she hyperventilated, and then she could hold her breath for 1.5 minutes. So people after hyperventilation are very good at holding their breath. But if it doesn't work, if it still doesn't work, and in our experience, in our sample, we have about 2,500. It was less than 5% who couldn't do that. But if people really can't do that, we are currently working on AI using just the first 2 cardiac cycles after the hyperventilation. And this looks promising, but it's still early to say. We cannot, but we will have some data soon, and then I can also disclose them. But as far as what I'm allowed to say right now, it looks very promising. Yeah. So what I wanted to also comment on what you said before with the inflammation. I think a key factor, and for those who are those of you who are in research, I think that's a very interesting research area. I think one of the key factors in the connection between inflammation, oxygenation, tissue injury, simply is myocardial edema or cerebrovascular edema or cerebral edema, because we know that edema compresses capillaries. So even though you may have a good endothelial function, if the capillaries are compressed in the outside, they just cannot increase their size. So there's a quote-unquote endothelial or vascular dysfunction, but it's caused by inflammation. And so this is where I think there is a strong link. And I also see there is a question here, why we use cine sequences. And this is the other interesting aspect. Only with cine sequence, we have the high temporal resolution we need. If we use a T2 map, for example, or T2 weighted imaging, we take 10, 15 seconds to get one image. That doesn't help. Yeah. We need to have more information. And if we get a full cardiac cycle every 3-4 seconds, and now we have some early developments with Siemens and GE and also Philips to increase the temporal resolution even more, so that we can have 3 slices within 3 seconds, and then you have enough data points to track what's happening during the breath hold. And you cannot have that with kind of a standard T2. And then the other aspect is the true FISP or SSFP or Fiesta balanced FFE, it's all the same. Because it's T2 over T1, we have T1 information there. And with that T1 information, we can reconstruct late gadolinium. We can even, this was, we presented that at the ESC a few weeks ago. We can even reconstruct perfect T1 maps, perfect T2 maps from these images. And we can do this for several stages of the protocol. So there is no way any other sequence can give us that rich information where we need AI to extract it, but we have these tools now.
Maybe it is important to check patients who have already high values of T2 mapping, such as patients with hypertrophic cardiomyopathy, kidney disease, or myocarditis, and check them with bold sequence and see how edema may influence this, the results of this.
Yeah, Sophie, we have already done that, and it's fascinating. In heart failure with preserved ejection fraction, this is what we are seeing. We're even seeing that women, when they are stressed, and we've seen this in our cohort trial in Montreal, stressed women behave differently. They have a higher T2 and associated a reduced response when compared to women without stress. Whereas in men, there is no difference. Apparently, we men, our heart is not affected by stress as much as women's hearts are. And that's why I think we have disease like HFpEF, primarily postmenopausal women associated with edema, microvascular function, dysfunction, and stress-induced cardiomyopathy as the maximum event, where you also have massive edema, massive microvascular dysfunction, and even going into heart failure. So we have already preliminary data, and there is a study that is currently under revision from a group in Portugal. They could show the same thing. They could confirm that, and this paper hopefully will be published later this year.
Okay, thank you.
Okay, thank you very much. I don't think we have more questions to address, so we can proceed to our next speaker. Thank you.